Things Insulin. So we are going to walk through the different trials over the last several years in chronological order, and we're going to be talking about insulin management in patients and different types of patients, but the majority of the patients are going to be, for the most part, critically ill patients that we're going to be talking about right today. And so let's go over them, and we'll start with Vandenberg in 2001.
So in 2001, this study included a population of all adults receiving mechanical ventilation who were admitted to the intensive care unit, specifically the surgical ICU.
Okay.
The different interventions included our intensive versus our conventional. The intensive therapy was insulin infusion started if blood glucose was greater than 110, with a goal of 80 to 110.
So the intensive was?
Initiating insulin when blood glucose was greater than 110.
Okay, so they would initiate if it was greater than 110, but the goal was?
80 to 100.
Okay. I think it was to 110.
110.
Right? Okay. Okay.
And the conventional was starting your insulin if your blood glucose was greater than 215 with a goal of 180 to 200.
All right. So that one was, they would do if it was a greater than 215?
Yes.
And the goal?
180 to 200.
180 to 200. Okay. Alrighty. Keep going.
The Apache score for this patient was approximately 9.
Okay.
And the hypoglycemia was defined as blood glucose of 40 or less.
So what's the significance of telling us that?
Of the hypoglycemia?
How they defined it?
Oh,
Do you think that's normal?
no. So usually we define hypoglycemia as less than 70, so they define it at a much lower rate than.
So the purpose of pointing that out was that their definition is very, like, not necessarily a normal definition that I would go with. We typically think of less than 70, less than 60. So they're probably really, like, underestimating the number of patients that potentially had hypoglycemia, right? Yeah. Okay. All right.
Okay, so the number of patients was 1548, and they needed 2,500.
So the number of patients they needed was?
2,500.
Okay.
And they enrolled 1,548, or 1,548.
And they needed 2,500?
Yes.
Okay. All right.
For the feed, the intensive group got 18.5 kilocalories per kilogram of the non-protein calories, and the conventional received 19.1 kilocalories per kilogram.
So how were they getting it?
Enteral feeding.
Were they? Really?
Or actually, no, the enteral was the nice sugar.
So they were primarily getting like IV, like dextrose day one, and then they were getting enteral nutrition. So the point being that so they were getting enteral nutrition or TPN, and so a lot of the patients in this trial, I mean, a handful of them got TPM, which isn't necessarily normal. Like, we don't normally like start doing TPN early, right? And so when do we normally start TPN?
If they're projected to be NPO for greater than 7 days.
Yep. So you think that someone being on a TPN versus enteral nutrition, which one do you think would be better if you were talking about from a sugar standpoint?
The enteral nutrition versus the TPN. The TPN would increase the opposite. The enteral, the enteral feeding would be worse than TPN in terms of sugar.
Well, when you're looking at someone's sugars, right, if you're trying to see if someone's becoming hyper or hypoglycemic, which one is going to be more consistent? So a TPN, we know 110% they're getting all the calories that we're giving them. Enteral nutrition, I don't know if they're going to tolerate their tube feeds or they're not. Are they going to have high residuals? Did they get stopped for a procedure? Are they off? Are they on? So those things could all affect someone's overall what their goal or their sugars were, or impact the ability to monitor someone's glucose levels, right? So although we don't like to give TPNs early, someone on a TPN is probably a little bit more easier to like maintain their sugars on, because I know consistently that they're getting the feeds that I'm giving them, right? So what was the primary outcome?
The primary outcome was death from any cause during the ICU stay.
Okay. And
for the results in the intensive group, that was 35 patients, or 4.6%.
4.6% mortality, right?
Yes. And then in the conventional group, it was 8% mortality.
Versus 8%. 8%. Okay. And so let me just look at what I had here. So the number, so it was 64, so it was 64 patients, right? 64 patients, or like 8%, right?
Yeah.
And the other one was
35 patients.
35 patients, or 4.6%. Okay. Great. All right, so what other things do we think that would be important to mention from the results standpoint? Although not the primary, but what other things would you want to maybe at least mention?
In the conventional group, there was longer ICU care and increased renal impairment, and also sepsis with the use of antibiotics.
Well, you told me how they defined hypoglycemia. Do you want to maybe tell me how many patients actually had hypoglycemia in each of the groups, right?
Yes.
So in the intensive group, they had, how many patients had hypoglycemia?
39.
Yep, 39 patients had hypoglycemia, which is a decent amount, right? It's almost as many patients as they had, potentially meet their primary outcomes, so this is equal to the number of patients. So that'd be interesting. Did the same number of patients die? I mean, I don't know. I'd have to look. Versus in the conventional group, how many patients had hypoglycemia? 6 patients did. So they're probably really underestimating the number of patients that had hypoglycemia, because, like as I mentioned, because they defined hypoglycemia, which really should be severe hypoglycemia, by having a sugar less than 40, right? Okay, so what was the overall conclusion?
The overall conclusion was that the use of intensive insulin therapy reduced mortality in the ICU, in-hospital mortality, and morbidity among the critically ill patients.
So reduces morbidity and mortality among ICU patients. So they were saying that we should really maintain that tighter intensive goal of targeting of 80 to 110 for patients. again, these were primarily surgical patients. Do you want to take it a step further and tell me the type of surgical patients that they really were?
It was a cardiac patient.
Yeah, so they were primarily cardiac. All right. So any other, like, limitations that you can think of as a whole?
So as a whole, since this is limited to the cardiac surgical ICU patients, you cannot extrapolate it to the other intensive care units, which we'll talk about next. So it was like the main thing that I had.
What do you mean when you're looking at statistical analysis? Isn't there something else that you?
And it still didn't reach the power.
Yeah, so they didn't have enough patients. Right. That's a problem, right? So because what's the argument if you don't have enough patients?
That you're not able to truly detect a difference.
So the argument is that you might, if you, they found a difference here, right? That was statistically significant, right?
Right.
So the argument really is that if you don't have enough patients and you find a difference, well then, yay, rah, rah, shish kebab, right? But if you study something and you find no difference, the argument is that if you would have included more patients, then you would have found a difference. So that's where power comes into play. So maybe them not having enough patients is as much of a critique or limitation in this situation because they did find a difference in the number of patients that they did end up having. So a little different, right? Okay. Let's go on to the next one by, again, Vandenberg, who is a woman, and she came up with another study in 2006. And what did she find?
So in this study, they included adult medical ICU patients who were assumed to require at least 3-day stays in the intensive care unit, and they excluded SICU patients or surgical ICU patients and those receiving oral nutrition.
Okay, so excluded surgical and if they got oral nutrition. Okay, keep going.
In the intervention group, the intensive group included it was similar. You started the blood glucose, or you started insulin when the blood glucose was greater than 110 with a goal of 80 to 110. And the conventional was also similar. You started insulin when the blood glucose was greater than 215 with a goal of 180 to 200. Here the baseline Apache score was approximately 23, and also 24 when you looked at the ICU length of stay for greater than 3 days.
Okay.
So hypoglycemia had the same definition, defined as blood glucose of 40 or less. They needed 1,200 patients, and they enrolled 1,200 patients. Here they started feeding when the patient was hemodynamically stable.
Okay.
And the primary outcome here.
Hold on, they started feeding when they were stable, but more of these patients received enteral nutrition in comparison. I'm trying to look and type at the same time, and it's not working out very well. Compared to the 2001 trial. Okay. Okay, so what was the primary outcome?
The primary outcome, they looked at death from any cause in the hospital.
Okay.
And the primary results, they did not find statistical significance in these patients. However, when they looked at ICU at day 3, it was...
Well, let's hold up a minute. So for the purpose of the primary outcome for the intensive, what did they find percentage-wise? So they found it was that 37.3% 3% in the intensive arm. That was their mortality rate.
Yes.
Right? And I don't know if I have the exact number of patients written, but that's fine. And then the conventional was 40% of patients died. So they ultimately found no difference between the groups, right? But let's also see what they commented on regarding the incidence of hypoglycemia, which I don't know if I have that written. Do you have that written by chance, Megan? I can easily pull it up.
A number, it just says more.
The number of hypoglycemia, I thought I had it exactly written down, the incidence. Well, we can come back to that. But the point is that it's also probably similar in the intensive group.
I have it here. So hypoglycemia occurred in 39 patients in the intensive treatment group.
And this is the 2006 trial?
Oh.
Because I'm like, that's exact from the other one.
That's why.
Oh, that's impressive. Whoa. Same exact result. Let's flip around.
Oh, yeah, no, I don't think they... Okay, this is mortality. Yeah, hypoglycemia occurred more often in the intensive group.
But do they have numbers?
I don't see numbers here.
Really? Interesting. I'll say they just said more often. Well, anyways, that still holds true regarding the fact that the blood glucose cutoff is obviously poor, so we won't put down the exact number of patients like we did in the other one. That's fine. But overall, what they did find was specifically that they found that among, the patients that stayed in the ICU for greater than 3 days, so that was 767 patients that were in the ICU for greater than 3 days. They found what?
They found statistical significance between the two, so it was 2.8% for the intensive group and 3.9% in the conventional.
So overall,
They concluded that intensive therapy prevented morbidity but did not significantly reduce mortality, except in the patients with length of stay in the ICU for greater than 4 days.
Well, go back and tell me the percentages between the two groups. You said that you had those?
Oh, yeah, sorry, 2.8% versus 3.9%.
So 2.8 was what?
The intensive group.
That was the mortality?
Yes.
Versus the conventional. Was, say that again?
3.9%.
So that was statistically significant.
Yes.
Which I have it more so written down as the fact that they were able to, the intensive insulin therapy was able to reduce overall mortality by, I think, 52 to 43%, which was statistically significant. Right?
Yeah.
So what table is that on? Or where did you get your percentages?
Oh, right here. For all patients, mortality in the ICU at day 3, it's on page 456.
Yeah, the bottom right.
Okay. For all patients, mortality in the ICU at day 3,
Oh, this is at day 3.
which wasn't statistically significant. So that's not the percentage that we're looking for. So that's wrong. So basically what they end up saying, if you keep reading, so they say for all patients, mortality in the ICU at day 3 was 20.8% versus 3.2%, which is not statistically significant. And in-hospital mortality at day 3 was 3.6% versus 40%. We're not different in the two treatment groups. Beyond the 3rd day, so they had to stay in the hospital for longer than 3 days. Beyond the 3rd day of the intensive insulin therapy, the in-hospital mortality was reduced. So the in-hospital mortality was reduced from, it's like 52.5% to 43%, which was statistically significant. I have that p-value. I think it was like p was equals 0.009. Yeah. And death from all cause in the ICU appeared to be reduced as well. The effect on mortality among patients staying for more than 3 days in the ICU is shown in the most of the subgroups stratified according to diagnostic categories. So they were just saying, like, overall, that there was no overall difference in reducing morbidity, or there was a significant difference in reducing morbidity but not overall mortality among all patients, right?
Right.
So the intensive insulin therapy significantly reduced morbidity, but not mortality among all patients. However, mortality was reduced if they got the intensive insulin therapy and were in the ICU for greater than 3 days, right? That's the only time that they saw it, right?
Yeah.
Okay. So what are some of the limitations with this one?
Here, I said that it was unclear whether intensive insulin therapy caused harm in less than 3 days in the ICU.
Say that again?
That it was unclear if there was any harm in the intensive therapy group in the ICU for less than 3 days.
It was unclear if there was harm?
Yeah.
What do you mean?
If there was any
harm caused in the ICU? I don't understand.
harm, like any side effects from major side effects.
If they were
in less than 3 days.
Okay. Well, we don't have what would you say is harmful if there's no difference? Right? It wasn't studied that way.
Right.
You know what I mean? I'm comparing the two groups. All I can say that there was no statistical difference in overall mortality. I would have to do another study to do a hazard ratio or something to assess if it wasn't set up to a superiority
Okay.
study. It was just comparing the two groups. So I can't say that.
Okay.
All I can say is that there was no difference among all patients at 3 days. Amongst all the patients, the only difference that they were able to see between the groups is if they stayed in the ICU for greater than 3 days. Limitations, I guess you could just say, it was, again, this one was only medical ICU patients. And you could argue, like, because they were getting, tube feeding, like, questionable, like, if everyone, was really getting all the tube feeds that they were supposed to be getting and tolerating them, right? Okay. Well, let's go to the last one. So the last one is what?
The nice sugar trial. This one looked at adults in the medical ICU and the surgical ICU in 42 different hospitals expected to be in the ICU 3 or more days. Here, the intensive therapy was to target blood glucose of 81 to 108.
Okay.
And the conventional was to administer insulin therapy if blood glucose was greater than 180 with a goal of 180 or less.
So the intensive was, when did they start it?
They started when it was, actually, forgot to write that down.
I think they just had the range. They
Yeah, I don't
said
think
goal.
they specified
They
when
just
they began.
Goal of 81 to 108 versus the conventional.
Yeah, in the conventional, they specified that they started when blood glucose were.
They had to have 2 ranges in one of them. So the conventional was if it was greater than
180.
Okay. Well, they were targeting really. But they were targeting overall less than 180, right?
Yes.
Okay, so the Apache scores.
The mean Apache score was 21.1.
Okay.
And they also defined hypoglycemia as blood glucose of 40 or less.
Okay.
Here, they randomly assigned 6,104 patients.
6,104. Okay.
And they needed 6,100.
Oh, they got 4 above. How nice of them. Okay.
Okay, so for the diet, these patients only received enteral nutrition.
So definitely more than, TPN, right? They primarily get enteral nutrition. And then what was the primary outcome?
The primary outcome was death from any cause within 90 days after randomization.
Okay.
And the percentages of that was in the intensive group, 829 patients, or 27.5% experienced death.
All right.
And then in the conventional therapy, it was 751 patients, or 24.9% of patients.
Okay.
And this was statistically significant.
Yep, and so they basically found an overall
There was an
increase in risk of death. So there was an increase of 2.6% risk of death, basically in the intensive insulin therapy group, right?
Yes.
And then when they also compared the hypoglycemia, so in the intensive insulin group.
Yes, it was, in the intensive insulin group, it was 206 patients, or 6.8%.
206 patients?
Yeah.
Or is the conventional?
In the conventional, it was 15 patients, or 0.5%.
Okay. Overall conclusion.
The overall conclusion was that intensive therapy compared with conventional therapy increased the absolute risk of death at 90 days by 2.6%.
So we should not do,
Intensive therapy.
we should not do the intensive insulin therapy. Okay, so then you could take this kind of a step further. Obviously they had, you know, limitations, comments would be like there's obviously, you know, whatever, more patients in this, and it was obviously also mixed. The other thing I like to bring up is what is the current recommendation according to the American Heart and Diabetes, or ADHA?
Yes. So the exact statement is that they recommend a protocolized approach to the blood glucose management in ICU patients with sepsis, initiating when the blood glucose levels are greater than 180. And you want to target an upper blood glucose level of 180 or less versus trying to target 110 or less.
Okay, so this is kind of a little old school, but I like to make a point with this. And not all the information in here is like 110% up to date, but it's going to still make my point. So when I first came here, not first, but after I was here, I've obviously spoken at multiple of the preceptor development conferences, and one of the things I had spoken about was like evidence-based practice or evidence-based medicine, and how to incorporate that into like precepting, because maybe not everyone practices or teaches as much evidence-based medicine as perhaps I do. So what is the significance of that? And really, what is that like? Something that I harp on is like, we don't just look at the guidelines. We need to know the articles that support the guidelines, because that's where, again, we go and we say, well, the guidelines say that, but when you really look at the articles that made that recommendation, you're like, like, should that really be a recommendation? Or like, where are they getting that information from? It's really poor overall evidence. So that's, again, so when we looked at the sugar articles, we said, do intensive insulin therapy, don't do intensive insulin therapy. We're all over the place. At what point do we sit back and make our own decision? Or if we keep studying something over and over and over again, and we're eventually going to find a difference, or, you know, per se. So this is, again, and I kind of saw someone at Society of Critical Care Medicine use this as an example, which I'm about to get into. But really, what is evidence-based practice? So it should be a combination of the best research or evidence that's available. It should be your clinical expertise. In addition to, we need to take into consideration patient values and preferences. So I might look over the evidence. I know that if your hemoglobin is less than 7, I should give you a blood transfusion. Those are going to my clinical expertise. But if you're a Jehovah's Witness, like, I'm not going to give you a packed blood cell, right? So you still need to bring it back to the patient. So you should always make sure that we assess the patient, ask the question, acquire the evidence, and appraise the evidence, and then always bring it back and apply it to the patient. So this is a 58-year-old patient who is status post-CABG, post-op day 8, and obviously had some signs of sepsis, and the physician would like you or comes to you and asks you what an appropriate serum blood glucose target would be. He wants to know, what should he be targeting, and, you know, should he be starting all this insulin therapy? And so for our case, we might say our problem, or that we would be looking at to research our clinical question, would be cardiac surgery, severe sepsis, critical illness. We're looking at glucose control, and our comparison would be, would we be doing intensive insulin therapy or conventional? And so again, it's in-hospital mortality. And so for our patient, the clinical question might be, in critically ill cardiac surgical patients with severe sepsis, is intensive insulin therapy more effective than conventional treatment at decreasing in-hospital mortality? And so how do we make this determination where we need to find the type of study? And so based off of the type of question that you're asking will kind of impact the type of study you would be looking for. Since ours is a therapy question, we're probably going to be looking for a randomized controlled trial or a cohort. And so we see that as we go up, we kind of want to find evidence at the top of the pyramid. Now, we could maybe use a meta-analysis or a systematic review, but what are some of the issues with meta-analyses or systematic reviews?
You have to make sure that the articles that you're looking at are correlated, so it's not too different. So you're not comparing oranges to apples.
So you can have a lot of bias if you're just looking at a meta-analysis, right? So, because it might not perfectly match your patient or your population. So sometimes in therapy questions, it's better to find randomized controlled trials. And so that's what we're going to be doing. Obviously, there's different ways that you can go about doing that. So PubMed, probably the biggest way. So we go to PubMed, we type in cardiac surgery, glucose control, and the first thing that comes up is the American Association of Clinical Endocrinologists, American Diabetes Association, like we talked about. This might be outdated, but the overall recommendation is still very, very similar. And so they basically say that an insulin infusion should be used to control hyperglycemia in the majority of critically ill patients in the ICU, and their starting threshold is no higher than 180, and glucose should be maintained between 140 and 180, which I think that's what they still say when you just looked, right? So 140, 180. Although stronger evidence is lacking, somewhat lower glucose targets may be appropriate in select patients, so targeting 110, however, are not recommended. So this is like, oh, where are they getting that from? Scratch, scratch. Oh, well, maybe that comes from the original Vandenberg trial in 2001. But maybe that's like select patient population. Ooh, if I had to pick a patient population that I would target 110, who would that be? Surgical cardiac patients, right? Which all comes back, ooh, chills, comes back to the original trial that they did in 2001, right? So it's science if we don't just make stuff up. And so the starting threshold would be 180, and they're saying maintain the threshold between 140 and 180. So should I stop there? Am I done? Did I answer the doctor's question? No. Should I keep digging? The answer is yes, I should keep digging. So now I go to the surviving sepsis. Ooh, obviously it's not 2012 anymore. So we have more updated guidelines in 2006. But again, the overall recommendation is still very similar. And so they recommend a protocolized approach to blood glucose management in the ICU with severe sepsis, insulin dosing when 2 consecutive blood sugars are above 180. The approach should target an upper blood glucose level of less than 180 rather than an upper target of, they're saying 110. So they definitely say, oops, they should do, so starting threshold would be, we wouldn't really start anything until 180, and we should really maintain to less than 180. Oh, so did I find my answer? No. I went to 2 resources. Should I be done?
No.
No, I can keep going. So lo and behold, if I keep searching, the thoracic surgeons have their own guidelines for managing patients with blood glucose management. Who would have known? I didn't know when I originally did this, but so they do as well. And so they say that patients with and without diabetes with persistent elevated serum glucose should receive IV insulin infusions to maintain a serum glucose of 180 for the duration of their ICU. If patients are requiring, if they're going to be in the ICU for greater than 3 days, they actually change it a little bit. They say maybe we should keep it a little bit tighter, more like 150. So starting threshold, still 180, but maybe I should maintain you either between 140 or 180, depending upon how long you're going to be in the ICU. So where does a lot of this come from? Well, a lot of it comes from the NICE sugar trial, which again, we already said was over 6,000 patients. It was mixed, surgical and medical, and the conventional was primarily less than 180, intensive was less than, or 80 to 110, right? And they found statistical difference, basically saying, rah, rah, we should do conventional and target our less than 180. But if we go back to that original trial that you already told me about, which was by Vandenberg in 2001, like I had already mentioned, it was mostly cardiac surgery patients. Well, do you know where they conducted this trial? Well, I'm assuming not. But it was done in the northeast of England, very underprivileged. A lot of these patients had poor overall mortality outcomes for their cardiac surgery. Okay, so why is that significant? Well, because let's pretend, you know, we're comparing apples and oranges here, right? Are our surgeons better than your surgeons kind of thing, or are our patients healthier than your patients at baseline? Because we eat healthier than maybe their fish and chips that they eat over at in England, right, or whatever. So you have to take some of that stuff into consideration. So when we look at the overall mortality in the United States, on average, I would say mortality for cardiac surgery is around 1.8%, between 1.7 to 2.1 in the United States. And so you can see mortalities on the y-axis, right? And the number of cases is on our x-axis. And so we can see each little box here is actually a hospital, okay? And we have the dotted line that says an average mortality of, as I had already mentioned, of around 1.7%. So the worst case scenario in this situation was a mortality at this hospital of around 3.8%, again, average 1.7. But if we go to the original trial by Vandenberg, okay, the intensive insulin therapy arm had an average mortality of around 2.1% in those patients in relation to cardiac surgery. And the control arm was at 5.1%. So the point he was making was that no wonder there was a difference, because there was already a huge difference in mortality at baseline regarding like cardiac in relation to cardiac surgery. So would I expect someone to know this or look for this and where it was done and look at some of these other mortality things? No, probably not, but it's something to take into consideration. So because their mortality is so higher than what the mortality is in the United States, we really shouldn't even use this study. We should probably throw it out the window because it doesn't really apply to our patient population. And so what do we do here? This is, again, this is old. It says it's 110 to 140, so back in 2014, that's what we were targeting for a low and high. I'm pretty sure now, you can ask, obviously I always say double check with Doug, but the glucose stabilizer in the cardiac surgery patients, they target their low, I believe at, I think it's 140 and the high is 160. Otherwise, the majority of the ICU patients, they're targeting, I think, more closer to the 180 mark. So, you know, why did they do this a little bit of a slighter, more tight control? Well, because they felt like, you know, that they wanted to do something more intense for their cardiac surgery patients, but they didn't want to be as intense as doing an 80 to 110 target, but maybe not as chillax as maybe targeting 160 to 180 or 140 to 180. They wanted it closer to the 140, 150 range. So that's the importance of understanding the evidence. So we don't just look at a guideline. We should review all the evidence and apply it to our patient population. And that's how you really can understand gray areas and be able to speak to some of it and not just say what the guideline said. Make sense?